All right, welcome back to our next topic here. We're going to talk about range of motion in Chapter 3 in our Therax 1 course. Just to kind of remind you all, range of motion doesn't mean stretching, right? I think a lot of students kind of confuse that early on whenever we start covering this topic here. But just before we get into the lecture, I just want to make it pretty clear to you all that range of motion is different than stretching. So we're going to see the differences between those in our next two chapters. So chapter 3, we're going to talk about range of motion. Chapter 4, our next lecture will be about flexibility training and actually performing the stretch. So just wanted to get that out there before we move on. So you can read through some of our objectives here. But let's get into it. Okay, so first of all, what is range of motion? It's a basic technique used for an examination or an assessment from the PTA of movement and for initiating movement into a purposeful therapeutic intervention. So when we talk about range of motion, we're really looking at kind of two different musculoskeletal structures. We can look at joint range of motion, and we can also look at muscle length or muscle range of motion. So we talked about in our lecture the differences between those two. And just as a quick reminder, joint range of motion is something that affects the capsule of the joint, such as frozen shoulder, and muscle range of motion is more related to muscle lengthening. So if we want to improve joint range of motion, maybe we need to perform something like a grade 3 or a grade 4 joint mobilization, intense stretching, at end range positions. But we're really thinking of, more of the joint play. Again, something like frozen shoulder, we would see a capsular pattern evolve. So for the shoulder, we would see the highest degree of limitation in external rotation, followed by shoulder abduction, and then followed by internal rotation, which is, more of a functional assessment, reaching behind your back into your back pocket, or trying to, unhook a bra strap or something like that. With muscle range of motion, we're going to perform different types of muscle length tests. So very similar to what you see in this image down below here, we could actually come in here and measure the range of motion of the hamstrings. So using something like this position and a goniometer to actually measure hamstring length. So you'll talk about those kind of things when we get into our kinesiology course, and you'll understand what's positive for a muscle length test, what's normal range of motion for muscle length tests. So we can kind of tease those two out. The next thing that I want to talk to you about is what we call, under this bullet point here, a functional excursion, which just means, taking the joint from taking the muscle from its most shortened position all the way to its most lengthened, or vice versa. But these two concepts that kind of fall under this functional excursion would be active and passive insufficiency. And a lot of students mix these concepts up or don't just fully understand these concepts. So we're going to do a good job of explaining this. And I'm going to use this image off to the right to kind of explain it. So I wish I could pause this so that I could show you a little bit better, but we're going to walk through it anyways. So as this woman extends her leg at the very top, when the foot gets to here, the hamstrings muscles are in a very lengthened position. And just remember that when we're talking about active and passive insufficiency, we're talking about two joint muscles. So the hamstrings would be one, the gastrocnemius would be one, the rectus femoris would be one, the biceps brachii, triceps brachii. Those are the muscles that we're looking at when we're talking about active and passive insufficiency. Those are the main ones that we're going to talk about at least. So back to this image here, as the foot gets to the top in her full knee extended position, the hamstrings are on maximum amounts of stretch. We have lengthening at the proximal end here. Okay, the hamstrings work to extend the hip. The hip is in flexion. We also have at the very top of this image, the hamstrings lengthened over the distal end. Right, the hamstrings are the main knee flexors. So putting them on stretch in the extended position is how we get that passive insufficiency. And what passive insufficiency really means is that when this muscle is lengthened, these hamstrings are lengthened at both ends, proximal and distal, it's going to limit, in a lot of our patients, the amount of knee extension that we can get, right? And I had you do this little activity, just sitting down, listening to my lecture, sitting there in your chair, your hip is in flexion already, extend your knee as much as you can. You're going to feel tension in your hamstrings. And if you bend forward with more flexion, you're probably going to get, decreased knee extension. You won't be able to get full knee extension. So passive insufficiency, the muscles are lengthened at both portions of that joint, so proximal and distal, and it's going to limit range of motion on the opposite side. So it's going to limit knee extension. Okay? So that's what we call passive insufficiency. Now we can also think about the anterior side of this thigh, and there's a muscle here called the rectus femoris. That is also a two-joint muscle. It's part of the quadriceps muscle group. So the rectus femoris helps to flex the hip and extend the knee. Okay? So in this position, the rectus femoris is shortened here at the proximal end, and it is also being shortened here at the top of this movement with knee extension. So what does that really mean? Well, with passive insufficiency, we talked about it's going to limit range of motion, okay, on the opposite side. With active insufficiency, we're going to get less motor output or less strength because the muscle is too short to develop tension and really provide any type of what we call muscle performance, right? Strength, power, whatever it may be. And again, we're going to talk about a little bit later in this course a muscle length or a length-tension relationship. We want some stretch on the muscle to provide tension, which is going to allow us to actually get good strength output from that muscle group. So with active insufficiency, right, if the muscle is shortened at both ends, proximal and distal, we're going to get decreased strength output. The muscle is too short to produce tension, and therefore you're going to see decreased strength. Okay, so these are going to be two really important concepts. So I would star those, and maybe you can go back a little bit earlier on this slide and just remember those muscles that I talked about. Okay, hamstrings, rectus femoris, the gastrocnemius, biceps brachii, and the triceps brachii. Those are the muscles that I really want you to focus on as we start kind of learning about active and passive insufficiency. Okay, so here's just your definitions for functional excursion, active and passive insufficiency. Just remember, these are two joint muscles, okay, multi-joint muscles. So you can read through those definitions here, and you're going to need to know those for any quizzes that we talk about. So now let's move on to our different types of range of motion. And in a second, we're going to discuss indications and limitations of these different types of range of motion. So the first one we have here is passive range of motion, or PROM is what they typically call it in the clinical setting. This is where motion at a joint or a muscle is produced by an external force. So it can be either manual from the therapist or mechanical using like a stretch strap, some type of mechanical device. Okay, but here there is no active contraction from your patient. Everything is completely passive. Okay, and again, we're going to talk about why we'd use passive range of motion here in just one second. The next one that we have here is active range of motion, or AROM. This is motion that's produced by an active muscle contraction. So your patient is actually going to move through a shoulder flexion activity on their own, as opposed to passive range of motion where the therapist was doing that all for them. Okay, so active muscle contraction here. And then we also have active assisted range of motion, AAROM. I always think of that as AAROM. If you know what I'm talking about, then you know. But this is motion that's, a combination of the two. So we have this external force, maybe by the therapist or like a pulley device for the shoulder, and active muscle contraction. So we're going to talk about these all here, when we would use them, why we would use them, but we're going to use all of those in our clinical setting. So maybe let's just take a peek at why we'd use them and some of their limitations. So let's look at these indications, goals, limitations of passive range of motion first. So when are we going to use passive range of motion? Well, we're going to use it whenever there is acute inflamed tissues or acute pain, acute inflammation, or when active range of motion is contraindicated. So a lot of our surgical interventions, something like a rotator cuff repair, especially if it's a large one, there's going to be protocols that call for no active range of motion, no muscle contractions. Okay, so if that's the case, but we still want to maintain elasticity as one of our goals, then we can use passive range of motion in what we call protected ranges. So I'll give you a little bit of an example here for something like a shoulder, a total shoulder arthroplasty. So at times we can use passive range of motion in the early phases, but it's going to be a protected range. So maybe I can only go to 30 degrees of external rotation with the shoulder at its side, but the physician doesn't want the patient to do that actively. So I can set my patient up in supine and protect the shoulder with some wedges and things like that, and then I can maintain this elasticity and mobility using a protected range, passive range of motion. This is going to help prevent contractures of certain muscles, and we're going to get to that here in 1 second on what contractures really are. It can assist in circulation, and I think most importantly, cartilage nutrition. As soon as somebody becomes immobile, it kind of seems like counterintuitive, right? But you have to remember that our body responds to stress, and if we don't have stress, if somebody's immobile, then our cartilage is going to start breaking down at a faster rate than it would if we were just performing some type of movement. So we don't want that, obviously, right? And for somebody that's had a total shoulder replacement, they've had both of the articular surfaces replaced already, so it's not like that's going to degrade any cartilage there because it's been replaced. But something like an ACL reconstruction where they're not taking out any of the cartilage, they're just repairing and reconstructing a ligament, we really need to have good cartilage nutrition. So passive range of motion can do that for our patients. Some of the limitations from passive range of motion is that it does not prevent muscle atrophy. So if we're not using our muscles, if we're not contracting those muscles, they will atrophy some. And that's one of the things that we're going to have to deal with when we start talking about surgical interventions. If there is no active movement allowed, then we can only do what we can to minimize atrophy and keep our patients functional and decrease pain. So it's not going to prevent muscle atrophy. Okay. It also does not increase strength or endurance. Does not. Okay. And again, we're going to talk about what we call the overload principle in just a few chapters. We really need to overload muscles in order for them to either build strength or build endurance, and passive range of motion does not do that. And it's less effective than active range of motion. So we talked about in semester 2, the main muscle pumps of the lower extremities and those kind of things for preventing DVTs. Anytime that we have an active muscle contraction, we're kind of it's that milking action, right? We're going to improve circulation with active muscle contraction. So does passive range of motion, assist in circulation? Definitely, but not as well as active range of motion. So I really want you to be familiar with, the indications why we would use passive range of motion, some of the goals, and then of course these limitations here are going to be a big thing that you would need to study for a quiz. Now we can get to active and active assisted range of motion. These two are kind of grouped together because they are similar. But when would we use active or active assisted range of motion? Well, when the patient is now allowed to contract that muscle, we can start to use something like active or active assisted range of motion. If there is weakness and a patient can't move throughout the desired range, then we're going to have to use something like active assisted range of motion. So let's say that we're performing a shoulder flexion activity all the way against gravity. So maybe they're sitting or standing. they only get to about 90 degrees of shoulder flexion, and we really want at this stage 120 degrees. Well, that last 30 degrees is going to have to come from some type of external force, either manually by the therapist or mechanically, again, with something like a shoulder pulley device. So they can move the muscle, they can contract it, but they're not strong enough to get it to the desired range. That's when we would use active assisted range of motion. If they're strong enough and they can get all the way up to 120 degrees, and that's their limitation at this point via their protocol, then we don't need to use anything active assisted. So let's look at some of the goals. So very similar to what we saw with passive range of motion. It's going to maintain flexibility and elasticity, mobility of those muscles, but we also maintain contractility of those muscles. So following a surgical intervention, some patients have a really difficult time just even contracting their muscles isometrically. And that's an inhibition that is brought on by the central nervous system, okay? And it kind of has that fallout to the peripheral nervous system. So maybe they have some kind of inhibition because of pain or because of swelling. Those are very common. So in that case, we would want to reduce pain, reduce swelling, and then maybe they would have a better opportunity and chance at actually getting those muscles to contract. But we're going to help maintain contractility of those muscles. It's going to help prevent some muscle atrophy. Very important too on this next one is that it's going to help with sensory feedback from those contracting muscles. So they're going to gain some kinesthetic awareness, maybe some proprioception if we're challenging it with stability and things like that. So that's a really important aspect too. Of course, if we're talking about lower extremities, DVT prevention, like I just mentioned on that last slide, remember that our muscle pumps are the best way to help prevent DVTs, besides using something like compressive stockings, ACE wrapping, those kind of things, vasopneumatic compression. And then, of course, it's going to help with coordination and motor skills. Some of the limitations for active and active assisted range of motion is that it does not increase strength in really strong muscles. So I gave you an example. Let's say a patient comes in with a muscle grade of 4 out of 5. That's good. It's a nice strong muscle. They can move against gravity. They can go full range, but they just can't tolerate maximum amounts of resistance here. So gravity may not be enough overload to increase muscle strength from 4 out of 5 to 5 out of 5. If we wanted to increase that muscle strength, we would have to add resistance bands, manual resistance, free weights, something like that to really overload the muscle. But if we're using active assisted range of motion, right? And let's take our example from earlier. Your patient is moving into 90 degrees of shoulder flexion, but they're limited because they're weak. Then we have some carryover for these kind of weakened muscles. So at the example that I gave earlier, this muscle grade would probably be a 3 minus out of 5. Okay, they can perform some of the range of motion against gravity, but they can't get full range. Okay, a 3 out of 5 is the minimum that we need to perform full range of motion against gravity. So anything less than a 3, right, active assisted range of motion might actually improve some strength. So maybe we get it to a 3 out of 5 eventually, and then we can start overloading it in different positions. So again, make sure you know these limitations and the goals and indications. Let's look at some precautions and contraindications to range of motion exercises and activities. So first and foremost, range of motion should not be performed when motion is disruptive to the healing process. So for your rotator cuff repair, RTC, baby R, rotator cuff repair, that large tear that they just repaired, let's say they repaired the subscapularis muscle. Well, we know that the subscapularis muscle internally rotates the glenohumeral joint. We're going to avoid positions like external rotation because it's going to put that subscapularis on stretch. And we're going to talk about, these different surgical interventions, but when they repair that muscle, they're going to anchor it to the head of the humerus, right? And its insertion kind of near that lesser tubercle of the humerus. It's going to be anchored there, and if we stretch it and pull on it and create a lot of tension there, we have a chance to, again, disrupt the healing process and maybe even ruin the repair. So we're going to avoid things like stretching into external rotation, which is going to put the subscapularis on stretch. And we're also going to avoid things like active internal rotation, which again is going to put stress through that subscapularis muscle and the repair site. So we need to kind of think about those things as we move through this course. Just to be aware also too that sometimes range of motion can increase pain, and we don't want to increase pain in our patients. It may be a little uncomfortable, but we don't want to have pain. This is bad, right? And anytime that we are stressing tissues, we could also increase inflammation. So we don't want to cause more of an inflammatory process or period if it's unnecessary, okay? So we need to avoid inappropriate movements. And something that we're going to talk about too are just these different major surgery types. The one that I have here is a CABG or a coronary artery bypass graft. We're going to learn very quickly that certain movements are not allowed, acutely after a CABG. So we'll talk about the tube that your patients have to stay in, pushing, pulling, lifting more than a certain amount of weight, because it can, again, disrupt that surgical site. As far as some of the principles, procedures for applying range of motion techniques, we really need to prepare our patient for what's about to happen. So always remember that it's your job as the PTA or the PT to educate the patient first and foremost, and then gain consent, right? This is what I plan on doing today. This is why I plan on doing it. Are you okay with that? Yes or no, right? You want to make sure to describe the pain that they should be experiencing or the lack of pain, right? This might be uncomfortable, but we don't want it to be sharp and stabbing. We don't want significant pain increases here. And I am going to move your shoulder for you. So I don't want you to do anything. I want you to relax as much as you can. That's going to help prepare the patient as to what they should expect for this intervention. So what is the goal? Well, maybe it's just to maintain mobility and elasticity, and we don't want a muscle contraction. So that'd be like passive range of motion. Or maybe this is to increase strength in a really weak muscle, so we're going to use active assisted range of motion. I want you to move through this range of motion as much as you can, and then once you feel like you hit your end range or you just can't go any further, I'm going to come in and I'm going to help you get the extra range of motion that we need. Okay? You want to make sure to free the area of any types of restrictions. So tight-fitting clothes, pillows, bolsters, those kind of things can kind of get in the way. We want it to be free of any restrictions. It's also really important to position your patient appropriately. Body alignment, stabilization are all important. If we have let's say a muscle grade of 2 out of 5, okay, that means that they can't move their limb against gravity to full range, and they really can't move it much at all against gravity. Okay, so maybe we have to put them in an anti-gravity position to have the best, most appropriate intervention. And we're going to talk a lot about body alignment and stabilization when we get into range of motion and stretching in the lab. Really important because, first of all, right, we want to make sure that we are targeting the correct muscle group, and we don't want unnecessary compensations. Okay, so we'll talk about best ways to align the body and best ways to stabilize the body when we get into our lab. And then the next thing too is just make sure that you position yourself appropriately. Pay attention to your own body mechanics. as well as your patients, because we're going to be doing this hopefully for a really long time. You're going to make a career out of mobilizing patients and taking them through these range of motion, flexibility exercises, amongst other things. But if you're going to be doing this, for 12 to 15 patients a day, or 20 years, you want to make sure that you are putting yourself in the best position too, because if you're not healthy, then you're not at your best to help your patients progress. So really, really pay attention to your own body mechanics. Don't hurt yourself trying to move your patients, okay? Find out a way that's going to work best for you. So going over the application of the technique now, we're going to grasp the extremity around the joint and provide support to that joint. So it's kind of hard to explain this over a PowerPoint. So we're going to see this a lot in our lab session. You want to support areas of poor structural integrity. So if you know that certain segments are hypermobile, then you want to make sure to provide more support to those areas. You want to move the segment through complete pain-free range of motion. Pain-free is what we're talking about, to the point of resistance, okay? So we're not pushing into resistance. Remember, range of motion and stretching are two different things. With range of motion, we are going all the way up to the limit of tissue resistance, but we're not pushing into it. We're not stretching yet. We're just trying to see how much range of motion that is available to them at this current time. And we're going to perform these motions nice and smooth, rhythmically, therapeutically. I recommend about 5 to 10 reps of range of motion. This is kind of like the precursor to the stretch. So you should be taking your patient through, let's say you're going to stretch out the quadriceps, and you're not going to do it with hip extension. Either you're going to do it with hip flexion, okay? Because maybe that's too aggressive early on in this rehab phase. But let's say somebody comes in with a total knee arthroplasty, a TKA, okay? We really want to get flexion back. That's a really bad T. We really want to get knee flexion back pretty quickly. We have about a typical 3-month period to gain range of motion before we start having to worry about contractures and permanent decreased range of motion. So I'm going to start as soon as those staples are out and the healing of the surgical site, the incision, is good to go. I'm going to start stressing that tissue. I'm going to start pushing into knee flexion from like a supine or a hook lying position. So I'm going to take their knee through full range of motion without stretching it. And I'm going to do that about 5 or 10 times. I'm going to bend it, I'm going to extend it, I'm going to bend it, I'm going to extend it 5 to 10 times. And then after that 10th rep, I'm going to provide a little overpressure. And this is where range of motion turns into stretching, okay? So I'm going to give you a good example of this when we get into lab. But it's again really important that you do this step first, right? You want to make sure that you are letting the patient get used to the position, they feel that it's not threatening before you just go into a full-on max stretch. Okay, so application of passive range of motion. Again, movement is external therapist or mechanical force. Again, within the free range of motion, pain-free range of motion is what we're referring to there. This is not stretching. We're going to skip past this slide. Okay, so now let's look at active range of motion. So as soon as we're done with our passive range of motion, everything looks good. Our patient stands up, and now we're trying to progress to active range of motion. We want to really demonstrate first the motion that's desired using passive range of motion. So this is the motion that I'm going to have you perform. You show them first, and then you ask the patient to repeat that motion. And as they repeat it, you're giving them cues, verbal, tactile, maybe even pull a mirror in front of them for some visual feedback. But you're trying to, when they're performing this active range of motion, avoid any compensation patterns. You're trying to educate them on what's most appropriate as far as movement goes. Okay, so like a really common thing that we see after shoulder surgeries is they're going to shrug their shoulder blade up as they're trying to perform shoulder flexion or shoulder abduction. And And that's something that we really want to try to avoid. Now, I'm not saying that, you know, it's going to be perfect for your patients, but you want to make them aware of it for sure. Okay, so that when they go home and they're not right in front of you performing this, that they're performing it, you know, quality with quality reps. You know, we don't want just quantity, we want quality range of motion reps. So educating your patient is going to be something that is really important in this phase. If they need some assistance, then that becomes, again, active assisted range of motion, but only provide that assistance as needed for smooth motion and coordination of the movement. And again, remember, this isn't stretching, so we're not going to have them overstretch here, do anything. It's performed within the available pain-free range of motion. Obviously, there's some benefits to functional patterning as well with range of motion activities. So, you know, I think it's important that we, again, educate our patients. We're going to assist them in teaching activities of daily living, their ADLs and IADLs, okay? So this is why we're doing this movement. Like, we're performing shoulder flexions so that you can reach up high to grab your cleaning supplies. We're always trying to tie our range of motion and anything that we do in physical therapy into functional movements, right? We're not just doing it to do it. We want to make sure that it's achieving the patient's long-term, short-term goals, and that it's beneficial and functional for them. And again, the more we educate, the more that the patient values what we're doing in this clinical setting. So they realize the purpose of the range of motion activities. They understand the value of performing these away from the clinical setting. And we're trying to really assist in developing strong functional motor patterns. And here, you know, kind of some of the last things before we end this is that you're going to see maybe this in a clinical setting once or twice. We've kind of moved away from what we call this continuous passive motion. Wow, my lines are bad today, I apologize. This continuous passive motion, or CPM, this is all mechanical, obviously. Okay, so they would do this for your patients with total knee replacements. Basically, this is like a little mechanical sled that, like the name suggests, continuously moves their knee. We don't see these much anymore. They've done research and show that, you know, the use of these CPM machines aren't necessarily more beneficial than active assisted range of motion, but they are definitely more expensive. So for that purpose, you know, try to decrease any type of burden on the healthcare system financially. They've kind of done away with these CPM machines, but there is a chance that you might see those. So if you do, for sure, let me know if during your clinical rotation you see something like this. And that brings us to the end of our Chapter 3 lecture on range of motion. I hope this is beneficial. I always thank you for stopping by. You know, if you like the video, make sure to hit that like button, you know, share it with your friends if you feel like they could benefit from some of these lectures. Thank you so much, and I'll see you next time.